So for this morning, I was going to go over just a kind of peripheral nerve tumors in brief and kind of talk about the most common ones that we see and go a little bit over the pathology and also some of the operative techniques when taking these out. By way of introduction, kind of reviewing some of the anatomy that we all know. If you think about, if you cut a nerve in half, just the ultra structure of the nerve that we see when we're doing nerve surgery, the most superficial layers is epineurium. This is what we can grab a hold of when we're trying to move the nerve around. It's also what has some of the basal nervorum that provides nourishment to the nerve. There's a couple layers of this. One is around the entire bundle of fascicles, and then one kind of goes in between the fascicles. The next layer that we think about is the perineurium, and kind of think of this as just what bundles axons together or nerve fibers together and forms a fascicle. So if the epineurium binds multiple fascicles together, then the perineurium just binds multiple nerve fibers together. And then finally, we have the endoneurium, which is the connective tissue in between the nerve fibers. And that keeps, that's kind of the glue that keeps the nerve fibers together within the fascicle. And the endoneurium is also what is in between the Schwann cells. And the Schwann cells provide the myelin sheath in the peripheral nerve system, peripheral nervous system. And so these layers become important when we start to think about where nerve tumors arise, and then also how we go about removing them. This is a little bit more of a zoomed in slide that shows the same things. Here, just wanted to kind of draw your attention to, you can see these nerve fibers, which are a combination of axons and myelin sheaths from the Schwann cells, and then the endoneurium, which is in between the two. So although there are many tumors we think about with the peripheral nervous system, whether paragangliomas or schwannomas, neurofibromas, different types of schwannomas, different types of neurofibromas, we're going to talk just in general about three different categories. So the first being a schwannoma, the next being a neurofibroma, and then finally this kind of broad category of bad actors, which are malignant peripheral nerve sheath tumors. So schwannomas also can be called neurolimomas. They usually affect patients between 20s and 40s. There's no predilection for sex. It can happen, males or females, and they can occur anywhere where there is a myelin sheath. So this can be as the roots coming out of the spinal canal all the way down to the target organ. And so it can happen anywhere in the body. There's a lot of kind of talk about what tumors are encapsulated, which are not, which have pseudocapsules, which don't. But schwannomas in general are thought to be encapsulated, but they are only due to proliferation of Schwann cells. So unlike a neurofibroma, you don't have these many different types of cells also included within the tumor. Now, they can be sporadic, which is most often what we see in clinic, or they can be associated with different neurocutaneous syndromes like NF2, where you would see a vestibular schwannoma, plus you can see schwannomas other places in the body, or you can see this in schwannomatosis, which is just another syndrome where multiple schwannomas are found throughout the body, but you don't typically have these vestibular schwannomas, which are the hallmark of NF2. Now, typically they're slow growing, they don't cause any pain, and usually don't present with a deficit. And so when we see these in clinic, a lot of times they're found incidentally. And so the mainstay of treatment really is observation, just to make sure that this is not something that is growing larger and larger and begins to cause either pain or a deficit. And then schwannomas are less likely to have malignant transformation. And so the chance of a biopsy-proven schwannoma becoming malignant is very low. Now, the way that these grow, they grow eccentric to the underlying nerve, meaning usually there's a nerve fiber that's involved. It pushes the nerve fascicles out of the way, and so you have this kind of appearance of a ball in a basket or something like that, where the fascicles have been displaced. And then it usually presents eccentrically to one side, which is good for excision because this allows a clear pathway in between the nerve fascicles to remove the tumor. Now, there are a lot of different ways to look at schwannomas on imaging. There are a lot of these different signs that neuroradiologists talk about. The truth is, it's very difficult to tell the difference between a schwannoma and a neurofibroma. And it's difficult to tell the difference between a neurofibroma and an MPNST in a lot of ways, a lot of times, especially with those with NF1. But there are a few of these signs that we can talk about: target spot sign, split fat sign, vesicular sign, so on and so forth. That kind of clue us into what this might be. Also, they're generally isointense to muscle on T1, and it can be hyperintense on T2, and they don't restrict diffusion. So, starting at this, the pictures on the left-hand side, A is a T2 weighted sequence, and you can see it's hyperintense. So it's hyperintense to muscle on T2. Then on B, it doesn't restrict diffusion. Then on C, this is a T1 weighted image. And on T1, we know there's fat. Fat appears bright. And so you can see this little golf ball looking thing here. There's a couple things that stick out. One is that you see this fat around the tumor itself. And then you can also see the fascicles and what they say a tail sign, which is a fascicle here. So you can see these fascicles come down. You see the ball or the golf ball, and then you see the fascicles going away. And so that's the that split fascicle sign, or then split fat sign above and below, where you can see the clear delineation of that bright fat around the tumor. If you were to do any type of arteriography, you would see that it's it can be vascularized, and so you can see some contrast uptake on that. And then on post-contrast imaging, it's going to be bright, and it's going to homogeneously enhance. The pictures in the middle here are just kind of reiterating some of the pictures on the left-hand side. And here the split fat sign is even more apparent. So you can see fat above and below the tumor, and then as well, well circumscribed tumor in the center, which enhances on B. And then on imaging that is a fluid sensitive, you can see, like a T2 sequence, you can see this target sign, which is a darker center, brighter kind of halo around the lesion. Then, of course, proximal to that, you can actually see the nerve itself. So these are a few hallmarks of schwannoma imaging. And truthfully, you can see a lot of these things with neurofibroma imaging as well. Now, this is kind of going back to boards and all the rest, but there are a few things, histological findings that should make you think schwannoma, at least if you're taking a test. But Antoni A and B and Verocay bodies, there is, again, Schwann cell proliferation in these tumors, but it's not usually, they don't usually include multiple other types of cells within the tumor itself. And then again, schwannomas are thought to be encapsulated with a distinct capsule around this Schwann cell proliferation, as opposed to neurofibromas. And so if you were to take the tumor out, cut it in half, then what we see is this kind of light tan appearance. I mean, this can be variable. Sometimes we see more of a bluish or a grayish appearance. And then some of these schwannomas, like ancient schwannomas, can also bleed or form calcium. And so within the tumor, you can see old blood products, hemosiderin, you can even see pieces of calcium. And then around this, you have this fibrous capsule as well. And then this becomes important for tumor resection because it provides a very nice plane in between the remainder of the tumor and the pseudocapsule, which will contain the rest of the nerve fascicles from the nerves from the parent nerve. And again, this is kind of going back, and it's not necessarily as relevant to clinical practice, but we think about these Verocay bodies with rows of palisaded nuclei, and then kind of this acellular pink basement membrane in between. And then think about regions of high cellularity with spindle-shaped nuclei with Antoni A configuration, and then with B, you have this disorganized matrix. And so, again, not so relevant for clinical application, but this does kind of, these are kind of the board questions when it comes to peripheral nerve histology. Now, neurofibromas also affect young to middle age, but we see it in all ages, especially in those with neurocutaneous syndromes. Whereas Schwannomas present with, very usually present asymptomatically, neurofibromas can have some mild to moderate sensory or motor symptoms. They can be isolated or sporadic, or they can also be associated with those things that we were talking about before. Now, neurofibromas come in different flavors. The plexiform is kind of the most intimidating, which is you see this tumor that just follows the nerve fascicles all the way down, so almost the entire length of the nerve. And these are not resectable. There's no discrete tumor to remove. It goes in between the fascicles, and the only way to remove it would be to sacrifice the nerve. And we see this with NF1. You can also see diffuse neurofibromas, and this is what we think about, again, with neurofibromatosis type 1. You see these multiple subcutaneous nodules that are easily removed and don't cause any type of neurodeficit. Or it can be localized, so it can just be found within the nerve itself, and it can be contained to just involving a handful of fascicles, so that resection is possible without a large deficit. As we talked about before, these neurofibromas also are similar to appearance to Schwannomas on imaging and have these similar signs. But what I wanted to point out are some of the differences here. And so this is an MRI looking at the nerves coming out of the brachial plexus, including some of the intercostal nerves down the chest, and you can see the sympathetic chain as well. And then this is these are plexiform neurofibromas. So there is no discrete tumor visible. It's just all thickened, involved nerve all the way down. And again, there's really no possibility for resection here. There have been some reports of using kind of advanced imaging to go in and see if there's an area that is more suspicious for malignancy and doing a limited resection of that area. So removing just part of a plexiform neurofibroma. There are also reports of people going in and trying to relieve compression to these elements, because as the nerve swells, then they can become painful. But truthfully, there's not much of a good treatment for this. And then the image on the right is just showing that there's no restricted diffusion. This is another example of this is a picture of the lower extremities looking at plexiform neurofibromas. Now in this one, you can see that it has a little bit more of a lobulated appearance. And this is the place where it's possible to go in and do a localized resection of an area that is growing more quickly than others, or it's a little bit more suspicious, maybe on like PET imaging or something like that. Now, histologically, these are thought to be non-encapsulated. So whereas the Schwannoma has a very distinct capsule around it that separates it from the pseudocapsule, not true with the neurofibroma. And then there's none of these Verocay bodies or nuclear palisading. Now, just like a schwannoma, these arise from schwannomas. It means a nerve sheath tumor, but other cell types are also involved. And so you can have fibroblasts and mast cells, you know, perineural cells, etc. So this is a, you know, thinking of this tumor, it's less organized, I should say. It's not as discrete within the nerve itself. And so resection of this type of tumor also becomes more challenging. So Klein has a series looking at resection of nerve tumors. You know, 90+% of schwannomas can be removed without a new deficit. Now, this drops down into the 80s for neurofibromas. So resection is more challenging, and it's also a little bit more risky. And it's inseparable from the nerve. So it's something that can be debulked, but some fascicles have to be sacrificed in order to remove this type of tumor. And then this is just an example of very large neurofibroma. And then here, really, this is going back to boards, but you can see that there are a lot of Schwann cells with a lot of other types of cells within this kind of this loose organization, both inflammatory, perineural, and Schwann cells. And then markers for these tumors are variable. You know, there's a couple things that we do think of, you know, all the time for these types of tumors. One being, you know, S100 stains very well in schwannomas, and then neurofilament can be present in neurofibromas, but not as present in schwannomas. And then there's some of these other markers that can also be used on when looking to differentiate the two. I thought this was a very good example of what I was trying to explain when you're comparing schwannomas to neurofibromas, and also something that's applicable to clinical practice, which is with the schwannoma, you can see that the tumor itself is eccentric to one side and displaces the fascicles around it. Now, there is a nerve fiber that's involved and often can be isolated and is non-functioning that can be removed from, you know, the superior pole and inferior pole of the tumor, but all these fascicles can be saved. And so there's no reason to sacrifice any of these transiting fascicles. Neurofibroma is a little bit more challenging. So it's less well organized. The fascicles are more involved, and it's difficult to separate this from the other, from surrounding fascicles. So classically with neurofibromas, you have to sacrifice more nerve in order to get this out. Fortunately, the nerve is often non-functioning. But also importantly, whatever fascicles are involved can often be separated from the other fascicles surrounding it. So say, you know, in the median or ulnar nerve, the proximal arm, just because there's a neurofibroma of the median nerve does not mean the entire median nerve has to be sacrificed. It just means that some of the nerve fascicles within that nerve bundle will need to be. Last one to talk about is malignant peripheral nerve sheath tumors. Again, these come in different forms. So this can be neurofibrosarcoma, malignant schwannomas, so on and so forth. Depending on who you read, it accounts for around 5% of all soft tissue sarcomas, with many of these occurring in patients with NF1. In fact, patients with NF1, there's around a 10% chance of malignant transformation over their lifetime of their neurofibromas, and so they are especially at risk for malignant peripheral nerve sheath tumors. They involve some of the larger nerves in the body, and also involve the lumbosacral and brachial plexus at times. Sometimes this can be secondary to prior radiation therapy, which is why we try to stay away from radiation and those with neurofibromas or with neurocutaneous syndromes. And then kind of the hallmark of an MPNST clinically is if you see a rapidly growing mass that is causing pain and is also causing a deficit. So whereas schwannomas and neurofibromas often are found incidentally, or they're found because someone can palpate a lump or something like that, MPNSTs present with a deficit. And so if I'm following someone in clinic who has a neurocutaneous syndrome and we're doing serial imaging, there's a couple of things that when I see them, I'm asking them about, which is any new numbness, tingling, or pain, and then on their exam to see if they have any new deficit, and then following their imaging to see if there's any rapid increase in size. Because if these things are true, then this is more of a indication to go in and remove the tumor. For MPNST workup, sometimes a PET scan can be helpful, but even so, even with the advances in technology, tissue diagnosis, like everything else, is the standard. Because nerve tumors are so difficult to resect the second time around, a lot of people will advocate for a gross little resection the first time around as opposed to a biopsy. That's how I was trained. There's others that always said for biopsy before doing a resection. But I think it's really patient dependent, and it has to do with your clinical suspicion for malignancy. And then these other things as well, perilesional edema, it can be cysts within the tumor, bleeding within the tumor, all these other things that can kind of, push you one way or the other, but are not definitive. And then these are just some pictures of terrible tumors. These are arriving from the lumbosacral plexus, looks like on A and B. And then you can see that there is some restricted diffusion within the lesion and central necrosis, kind of like we think about with a GBM. So this is a much more dangerous looking lesion. So instead of it being homogeneously enhancing, discrete, and not restricting diffusion, you have a restricting diffusion lesion with central necrosis and kind of this perilesional edema and fat stranding in the surrounding tissues. Just like we were saying before, actually, this is also a case of plexiform neurofibroma on B with what looks like a larger component that has some of these concerning radiological findings. So this is probably an MPNST that has arisen from these plexiform neurofibromas in the lumbosacral plexus in a patient with NF1. Another picture of kind of gross specimen here. And then histology on these tumors, what I think about is, there's increased cellularity, there's atypia, and then there's necrosis. So you can see that on 1C. Again, kind of what we think about with GBMs. So treatment for MPNSTs always is surgical resection if possible. Adjuvant radiation is also indicated. Chemotherapy is not great, but it's different targeted agents are being used now in trials to see if we can make that better. And then recurrence is high, and 5-year survival is not good. These tend to metastasize and recur, and lead to a very, very poor outcome. Now, with benign tumors, when we talk about surgical resection, kind of as I was mentioning before, there is a portion of the nerve that's going to be involved. With schwannomas, usually that's a very small fascicle or nerve fiber that can be resected without a deficit. In neurofibromas, there are more that are involved. However, the fascicles that are traveling around this can be saved. And so there's this kind of idea of a pseudocapsule around the true capsule of a schwannoma that contains these neural elements. And there have been some studies looking at this to see how much nerve tumor is actually involved or left over in the pseudocapsule on histological evaluation, and it's very minimal. And then leaving this pseudocapsule does not seem to predispose to recurrence. And so the pseudocapsule can be removed and serves at, can be left. It can protect the transient fascicles. So I just wanted to point out, a couple cases that I've had out here that I think better describe the technique. So this is a median nerve tumor in the kind of the mid arm, right between the brachial, the biceps and triceps, running along with the ulnar nerve would be further down and with brachial artery. And I think what's really neat about this picture is that you can see the median nerve, with that black arrow. So that's all the fascicles of the median nerve. So fascicles going to hand intrinsics, fascicles going to finger and forearm flexors. And then you can see this individual fascicle that's splayed out over this this tumor in the middle. And you can see multiple fascicles. So basically, as this nerve comes down, there was a tumor that formed, and it displaced, fascicle behind, fascicle in front, and fascicles inferiorly. And so when I simulated these all activate. So, this, was either forearm or hand intrinsics. Back here, forearm or hand intrinsics. And so these have to be saved. There's not a way to just lop this out without causing a large deficit. But what's nice, as we talked about with schwannomas, is that there is this, they grow eccentrically. And so they splay the fascicles out eccentrically. And so it leaves you a very nice corridor for tumor resection. And so when I simulated here, there was nothing. And so you can bipolar open the pseudocapsule, and then you can begin to remove the tumor out from the center of the nerve. And so this this pin field is just underneath the pole of the nerve tumor, and it has the nerve fascicle that's involved that doesn't stimulate. You can cut that, mobilize the tumor, and then cut the distal fascicle as well. And then you're basically left with a nerve that's functioning, that has a hole in it, but the fascicles themselves are not disrupted because you're able to do an interfascicular dissection or internal neurolysis without compromising function, just as if you're setting up to do a nerve transfer. This is another example that kind of shows the operative technique a little bit better than I could just, read off a slide. But this is a proximal arm median nerve tumor. This is a brachial vein, brachial artery with a loop around it. And this is a brachial artery, which has been mobilized up, and then deep to it is this, this mass. And you can see that with the right angle underneath the pseudocapsule, and there's multiple fascicles that are traveling in that pseudocapsule. And then ulnar nerve is underneath that brachial vein there. So once you open the pseudocapsule, you can deliver this nerve tumor out of the median nerve, past the artery and vein, and then you find again that fascicle. That is the kind of the culprit from which this tumor arose. You can divide that and then remove the tumor and block. Now, this is the surgical strategy is completely different for malignant tumors. As we talked about, these progress very quickly, and if it's associated with a neural deficit with pain, or if it's immobile and very firm, high suspicion for malignancy. If it's in someone with a neurocutaneous syndrome, high suspicion for malignancy. The problem with this is that very rarely do you find a nerve that doesn't run with a vessel at some point, or run with other nerves. And so getting a a resection with margins with a nerve tumor is difficult to do without completely compromising function. And so really discussions as really the kind of next step is determining kind of what family wants to do, what the patient wants to do, because resection with margins is going to leave you with a permanent deficit. And resection without margins will lead to recurrence. And so when I did these in training, a lot of times this is done with orthopedics because we're doing things like four-quarter amputation or limb amputation or something like this. So it's a combination surgery with vascular and with orthopedics. And this is not a enjoyable surgery in any way. And outcomes are really very poor. But for the right patients, especially those that are young, if it's an extremity, then it's something that can sometimes be treated with amputation. But often these are also deep-seated, like we saw, can be arising from the lumbosacral plexus, and these are inoperable a lot of times. That's all I have for today.
That's really really nice, Russell. A nice summary of that, and the operative photos are amazing. I was going to ask about the amputation or about how aggressive do people choose to absorb a deficit with a malignant tumor in order to kind of prolong life. And it sounds like the answer to that is yes in select cases.
Yeah, I mean, I think if it's, if it's involving an extremity, then people are a little bit more gung-ho about it, just like you would be for like an osteosarcoma or something like that. But when it's involving the plexus, then a lot of times, no.
Yeah.
Hey, Russell, you may have mentioned this, and I apologize if I missed it, but how do you localize the tumors, like the cases you showed? Do you use ultrasound, or can you palpate them, or use some other technique?
I ultrasound before those cases. So I try to get in the habit of every case using the ultrasound for these nerve tumors, or really any nerve case. And so I just have that before they're draped, marking that out.